Welcome to the conference session titled Understanding PNH. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMDSIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Bart Scott. Dr. Scott is a Director of Hematology and Hematologic Malignancies at Seattle Cancer Care Alliance. He is Associate Professor in the Division of Medical Oncology at the University of Washington School of Medicine. And he is Associate Professor in Clinical Research Division at Fred Hutchinson Cancer Research Center, all in Seattle. Welcome, Dr. Scott.
Thank you. It's my pleasure to be with everyone today. We need to update my bio because I've been promoted to full professor now. It's my pleasure to be with you, even though it's virtually. I really enjoy in-person meetings, but the advantage of the virtual is that maybe more people can be reached with this talk. And I've been tasked with the PNH session. And, one of the very interesting things about PNH is that we have some new treatments to talk about. And that's really wonderful for all of us, patients and physicians. So we'll get right to it. In regards to the name, it's actually kind of not named so well. The PNH stands for paroxysmal, and the technical definition of that would be that it comes and goes, but we actually now know that PNH is actually a chronic disease. There can certainly be time periods where it's worse, and people can have flares of their PNH, but it actually is a chronic disease. And of course, it's not just at night, which is where the nocturnal comes from. And then the hemoglobinuria is actually only seen in about 25% of patients with PNH anyway. So, I think if we had to name it today, we would probably come up with something different, but that's what we call it. And that was kind of our initial understanding of the disease, is that it came and went. It happened primarily at night, and most patients had hemoglobinuria, but we now know that most of that is untrue. So what is the problem with PNH? The principal issue with PNH is that the GP anchor protein that you see here, these are the blue dots that you see here. This is called a GP anchor protein. That's either missing or is highly deformative in patients with PNH. And you can think of the GP anchor protein as being the post of a flag. And that flag tells your immune system, are you playing for the home team or the away team? And so without that flag, sometimes it's difficult for your immune system to say, okay, is this someone that's part of my own body, or is this an intruder, an invader? And you can think of the GP anchor protein as the post to the flag, and you can think of CD55 and CD59 as actually being the flags themselves. And so all of your own cells are marked with CD55 and CD59. These are inhibitors of a part of the immune system called complement. And it's basically a way for your immune system to distinguish self from non-self. So when you're missing the GP anchor proteins, your immune system can't tell the difference between self and non-self. So in essence, PNH is an autoimmune disease. Why do you get it? It's an acquired disease, so it's not something that you're born with. And there's a specific mutation in what we call the PIGA gene. And the PIGA gene codes for this GP anchor protein. And it's an acquired mutation. And you can see that there's a number of different mutations that can result in patients developing PNH. And to date, more than 100 different types of mutations in the PIGA gene have been reported in patients with PNH. So it's not something that you're born with, it's something that you acquire. Why do you get this mutation? It's probably just happenstance. And in fact, we think that this mutation happens more frequently than patients who actually end up developing PNH, because we now understand that the mutation alone is likely not sufficient to develop PNH. And I'll come back to that a little bit later in the talk. When we think about PNH as a disease, there's basically three main categories. Classical PNH, which is characterized by intravascular hemolysis, that's where you destroy your red blood cells inside blood vessels. So intra means inside, vascular means blood vessels, hemolysis means destruction of red cells. So classical PNH is where you destroy your red blood cells inside the blood vessels. When you look at the patient's laboratory values, they typically have findings that show this intravascular hemolysis. I'm not going to go through these laboratory values in detail because they're kind of more specific for hematology, but we can look at these lab values and say, okay, this person's having intravascular hemolysis. And one of the things that we look at in particular is something called lactate dehydrogenase. And that's an enzyme released when red blood cells are destroyed, because lactate dehydrogenase, LDH, is inside the red blood cells. So when the red blood cell is destroyed, it releases the LDH, and the LDH levels are high. Now, that's opposed to extravascular hemolysis, which can also happen in PNH, and that the red blood cells are mainly destroyed in the spleen. But because it's happening inside another organ, the lactate dehydrogenase levels in the blood are actually not elevated. So LDH helps us to distinguish between intravascular and extravascular hemolysis. And that's going to be something important that we come back to. So that's one class of PNH. And if you look at these survival curves, historically, classical PNH has had the worst survival. But that's before the approval of a lot of the medications that we're going to talk about, and certainly before the approval of complement 5 inhibitors. And I'll just go ahead and tell you that in the era of the use of complement 5 inhibitors, the survivorship of classical PNH has improved drastically. Now, the other big group of patients with PNH are PNH patients who also have a bone marrow failure disorder. That's typically aplastic anemia, myelodysplastic syndrome, or myelofibrosis. So now you're kind of understanding why PNH is part of the Aplastic Anemia MDS Society, because PNH is frequently seen with aplastic anemia. And of course, classical PNH doesn't always happen with aplastic anemia. It can be seen by itself, but there's definitely a relationship between PNH and bone marrow failure disorders. So sometimes you can have both problems. Another group, the third group, tends to have the best prognosis, and this is what we call subclinical PNH. So these are patients who actually are not having any intravascular hemolysis. They have very low levels of what we call a PNH clone. And really the only reason why you know about it is because they happen to have some type of bone marrow failure disorder. So those are the three main groups that we think of. As I mentioned to you, historically, the survivorship with patients with PNH who had classical PNH is worse. In the era of complement inhibitors, the survivorship of patients with PNH is actually very similar to age and gender match control. So that's really good news. Classical PNH is a very rare disease, about 16 cases per million. It's diagnosed at all ages. The median age is in the early 30s. It's a progressive disease. Patients have uncontrolled complement activation, which leads to the morbidity and mortality. And despite best supportive care, historically, the 5-year mortality rate was 35%. But of course, that's much better. I've already kind of mentioned to you how these diseases are all related to each other, but there can be some overlap between PNH and these other bone marrow failure disorders. They have some things in common. The things that they have in common are a propensity to go into leukemia, overactive immune systems, and some type of underlying bone marrow failure disorder. So why is there this association between PNH and aplastic anemia? I've already told you that PNH cells are missing this GPA anchor protein. So they don't have CD55 and CD59 attached to the surface of the cell. We believe, or actually I think we know now, that in many patients with aplastic anemia, they have an autoimmune mediated, I'm not advancing my slides. I don't know why they're advancing on their own. Sorry about that, but we'll manage it. In aplastic anemia, the T cells can attack the own stem cells, but the T cells that attack the stem cells in aplastic anemia are actually directed against the GP anchor protein. So the PNH cells, because they don't have the GP anchor protein, are somewhat protected in aplastic anemia. So what we understand now is that this immune attack leads to a selective and growth survival advantage for PNH in aplastic anemia. So coming back to what I said in the beginning, the mutation alone we now understand is not enough to get the disease. You have to have the mutation plus some selective pressure. And that's been really borne out in aplastic anemia. And we know that in aplastic anemia, that selective pressure is an autoimmune mediated attack by the T cells against the GP anchor protein. And since the PNH cells are missing the GP anchor protein, they're not attacked by the T cells and they're allowed to grow and expand over time. So that brings the big question, well, why don't all PNH patients have aplastic anemia then? Well, that's a very good question, and it belies the other question, which is, why do patients with classical PNH get the disease? We don't yet know, but there's probably some other type of selective pressure that leads to the growth and survival advantage of the PNH cells in patients with classical PNH. But certainly with aplastic anemia and PNH, we have a pretty good understanding of why that happens. Let's spend a few minutes talking about complement, because understanding complement helps you to understand some of the problems that patients with PNH have. First, I should say, complement is part of our humoral immunity. That means that it's circulating within the blood system, and it's not cellular mediated. So it's not T cells, it's not B cells. It's actually proteins that circulate within our blood system, and these proteins are made in the liver. It's our first line of defense. So if you cut yourself shaving in the morning, if you cut your fingers, one of the reasons why you don't get bad bacterial infections in your skin all the time is because your complement immune system comes along and attacks the bacteria and kills it. So it's our first line of defense, very important part of our immune system. Any type of stress can raise complement levels. So if you get an infection, complement is higher. Surgery, complement is higher. Autoimmune disease, complement is higher. And pregnancy, of course. There's a little bit more detail about the complement pathway. There's two parts to the complement pathway. The proximal part, which is now shown here, that consists of this protein called C3. C3A is part of the complement that says that is kind of like the telephone lines. It's calling in help. It's called an anaphylatoxin. And it says to all those cell-mediated immunity like T cells and B cells, hey, come here, I found something, come help us. So anaphylatoxin is part of the signaling process of your immune system, basically to recruit cellular-mediated immunity to come along and help. It can cause a lot of symptoms: fever, night sweats, fatigue, muscle aches. That's when you feel like you've got the flu, when you get a viral illness. That whole process is driven by this anaphylatoxin, because it's basically saying, okay, immune system, get really revved up, because we're in for a fight, because I've found something that's infected our body. Now, the terminal complement cascade it also has this phone communication system called the C5A. It's a really potent anaphylatoxin. So C3A is a weak anaphylatoxin, but C5A is a very potent anaphylatoxin. And the terminal complement also makes this membrane attack complex, which can actually form holes in the bacterial wall and kill them. So that helps to kill the bacteria. We have natural inhibitors of complement, because complement's always turned on. And these natural inhibitors are the flags, CD55 and CD59, that helps to tell self from non-self. Well, now the problem in PNH, remember, is that you're missing these flags. So in PNH, the complement can't tell the difference between bacteria and your own cells. And the red blood cells are very sensitive to punching holes in their membrane surface because the red blood cells don't have a very malleable membrane surface. It's very rigid and structured. So if you make a hole in it, it can't really adapt. It's like, oh my gosh, I've got this hole in it. Well, the cell dies. And we call that hemolysis. So that membrane attack complex is what destroys the red blood cells. On the other side of the equation, C5a is what causes a lot of the symptoms in PNH, because that's the part of the immune system that's saying, I'm sick. I need to recruit other things to help me. It causes fevers, it causes muscle weakness. It also can activate platelets. So it has a role in blood clots. And blood clots, historically, were the #1 leading cause of death in patients with PNH. So now I think you can have a better understanding of how complement and PNH are related to each other. So here we have a graph of a normal red blood cell. Complement comes along, but these green dots are CD55 and CD59. They're the home flag, and they say, okay, complement, don't attack us. And the complement doesn't. But now over here, we have a PNH red cell. The PNH red cell doesn't have the G-pancoprotein that you see in blue. Therefore, there's no home flags because there's no flag post, no home flags can bind. You're making the home flags. You have the home flags. You just can't attach it because the flag posts are missing. So now this red blood cell is treated like a bacteria, and the membrane attack complex comes along, punches a hole in the red blood cell wall, and the red blood cell is destroyed. That releases hemoglobin. Hemoglobin binds to a naturally circulating compound in your blood called nitric oxide. Now, some of you may know that one of the common treatments that we give for angina is chest pain, is sublingual nitric oxide. That's because nitric oxide has as its role to dilate blood vessels to keep them open. But if you consume all of your nitric oxide because hemoglobin binds to it, you can't keep your vessels open. So what you get in patients with PNH is what we call vasospasm. And that causes a lot of the abdominal pain that patients with PNH develop because they get smooth muscle dystonias. It also causes the problems with swallowing. It can also cause erectile dysfunction in men, which is what all of this slide is about. And then the lower nitric oxide level also leads to platelet activation and aggravation. All right. So here we have all of the symptoms that we've kind of talked about that patients can get because of the vasospasms. And then the fatigue is in part due to this potent nephrotoxin C5a. Historically, there were not great treatments. Transfusions would cause iron overload. Things to prevent blood clots like anticoagulants, warfarin, Coumadin didn't work so well. If we gave people drugs like erythropoietin or darbepoetin to try to make them make more red blood cells, well, the red blood cells were PNH red blood cells, so that didn't really help. Steroids, that actually does help, but steroids have a lot of side effects. The prednisone can cause bone destruction. And so I have a lot of patients with PNH, and it's not uncommon to see the older patients with PNH who've been on and off steroids for most of their life to have a lot of joint replacements, hip replacements, knee replacements, to have a lot of osteoarthritis because of the chronic steroids they've been on. Transplant can cure patients with PNH, but there's a high upfront mortality rate, historically as high as 42%. We've gotten a little bit better with that now because we were better at doing transplants, but still the treatment-related mortality can be around 18 to 20%. So in the first year, up to 20% of patients with PNH can die from transplant. We talked about blood clots. Blood clots are the leading cause of death in patients with PNH historically. This is before the approval of eculizumab, a complement inhibitor. And there's many different pathways that leads to people developing a blood clot. So this slide is just basically to show you that there's many different pathways that leads to this blood clot. And that's why it's hard to prevent with like things like warfarin and what we call the DOACs, which are the oral anticoagulants, like enoxaparin, because these drugs can't block all of these different ways So there's these little microparticles of platelets that are circulating around. The C5a activates the platelets. The membrane attack complex binds to the platelets. So because of this, it's really hard to prevent unless you prevent the complement activation at the very beginning of this disease. We talked about LDH. LDH is a marker of red blood cell destruction. So the more red blood cells you destroy, the more likely you are to have a blood clot. There's a risk of what we call strokes. Strokes are blood clots that happen close to the brain. And if you look at the PNH population overall, they're 3 times more likely to have a stroke. And then if you look at just the younger population, they're 8 times more likely to have a stroke. And having a stroke, particularly in your 30s and 50s, can have devastating consequences for the rest of your life. If you've had one blood clot, you're 15 times more likely to actually die from PNH. And I just want to say, to be on a positive side of things, all of this data is before the approval of treatments for PNH that we're going to get to. What type of blood clots do people get? DVT. That's a blood clot in your legs. That's the most common type of blood clot overall. There are some unique blood clots that you can see with PNH that really would say to a physician, I should screen for PNH. DVT is not one of them. And that's because DVT is the most common type of blood clot overall. But you can get mesenteric, that's blood clots basically within the GI tract, and you can get blood clots within the liver. These are more indicative of actually having PNH. Taking anticoagulants doesn't really appear to reduce your risk of blood clots. That's what this is showing. You can see blood clots even in patients with what we call low PNH clone sizes. That's what this number is referring to at the bottom here, what we call a PNH clone size. There is a relationship between the amount of PNH cells you have and your risk of blood clots. And in general, the more PNH cells you have, the higher your risk of blood clots. But even in patients with a low number of PNH cells, you're still at risk for getting blood clots. The second leading cause of death in patients with PNH is kidney problems, what we call kidney disease. And 8 to 18% of PNH-related deaths are due to kidney failure. So if you look historically, about 60% of patients with PNH have some form of chronic kidney disease. And that's because when the hemoglobin is released from the red blood cells, it goes to the kidneys, it deposits within the kidneys and causes inflammation and destruction of the kidneys itself. Patients with PNH can have symptoms even if they have very low clone sizes. This is what this is showing. So you should not say that patients with low clone sizes can't have problems. So that's an important thing to know if you're a physician who's treating patients with PNH. Aplastic anemia. So this is looking at patients who have both aplastic anemia and PNH. And this is a prospective trial. And there were 75 patients who had PNH and with aplastic anemia and didn't really have what we would call bad PNH at the beginning. So kind of a low-grade PNH or a subclinical PNH. And the point of this is around 30% of patients had some expansion of that PNH clone over time. So if you have aplastic anemia and you don't need treatment for your PNH at the beginning, it's important to recognize that that could progress over time. So the PNH could actually get worse to the point where you need to be treated. If you have aplastic anemia and you did not have any level of PNH at the time you were initially seen, it is highly unlikely that you're going to develop a problem with PNH at a later time point. Only 4% of patients did. If you have PNH with aplastic anemia, you're much more likely to have an overall response to ATG therapy, and you're much more likely to have a complete response. So that tells us that if you're an aplastic anemia patient with PNH, ATG therapy tends to work very well. When you have a patient with both bone marrow failure disorder, that's typically aplastic anemia, MDS, with PNH, the principal treatment depends on their biggest underlying problem. So if it's blood clots, you should probably treat the PNH first. If it's the bone marrow failure, so let's say they're having problems with infection or bleeding, you should probably treat the bone marrow failure first. And the principal treatments for bone marrow failure is immunosuppressive therapy, IST, or hematopoietic stem cell transplantation. This slide was made before the approval of ravulizumab and now pegcetacoplan, but all of those would be available therapies for patients with PNH. It's also true that you can see PNH in MDS patients. And this is a historical study that looked at 1,293 patients with PNH. And you see that around 17% of patients had some degree of PNH with low-grade MDS. In regards to who should be screened for PNH, so if you're a physician out there and you're seeing patients in a clinical care setting, when should you consider PNH? If the blood counts are low and you don't know why. If the blood counts are low and they have a high LDH, which is a marker for hemolysis. If the blood counts are low and they have blood clots, that would be another reason to say, okay, maybe this patient could have PNH. How do you test for PNH? It's actually pretty simple now. So I grew up I'm older than I look. I always say, there's one advantage of Zoom is that you can't see the wrinkles, at least we hope. But we used to test patients for PNH through this ham sucrose hemolysis test, and it was a very inconvenient way to test patients with PNH. It wasn't very sensitive. It was a difficult test to do. But now we have a better way to do it, and it's a simple test. It's basically a blood draw. And you send that blood for what we call flow cytometry, and you can see a PNH population of patients that can be very, very small. But this is typically what you would see by flow cytometry on PNH in red blood cells. This patient has no PNH. This patient has PNH that you see here. And this patient also has PNH with two different marker populations, what we call type 3 and type 2 cells. With flow cytometry, you can actually look specifically if a cell expresses CD59 or not. We also look at what we call the granulocyte population. So when we talk about clone size among physicians, we're really referring to the granulocyte population. And in this patient, around 80% of the granulocytes are missing the GP anchor protein. So these are the normal granulocytes here in pink, and in blue are the granulocytes that are missing the GP anchor protein. So this is what we refer to when we say clone size. So this patient has a clone size of 80%, not 31%. We don't use red blood cells to determine clone size. And the reason why is because patients can be transfused and because the red cells are destroyed. So if you look at clone size in red cells, it should be in untreated PNH patients lower. So it's not as good of a level of the marker of their disease quantity. So we really look at granulocytes to determine clone size in patients with PNH. You do want to follow people over time who are at risk for developing PNH. That's basically what this says. All right, now treatments. So eculizumab was the first FDA-approved treatment for PNH. It is a monoclonal antibody, and it combines both human IgG and mouse. Murine means mouse. We don't like to say mouse to patients, so that's why we say murine, because sometimes mouse can be like cause patients some concern, but it shouldn't. But basically, this portion is derived from a mouse. It's a murine origin, and it's actually directed against human complement 5. And then it's combined with human IgG2 and IgG4. And then this eculizumab comes along and blocks the terminal complement cascade. So you're no longer making that membrane attack complex, and you're no longer making C5a. You are to a little bit, of course, but not in the high quantities that you normally would be if you had PNH. The proximal immune system, C3, C3a, and C3b, remains intact. So you still have some function of complement. Now, this could also be a problem, And we'll get to why that is the case a little bit later on in the talk. There have been a lot of studies evaluating eculizumab. So its safety profile is well known, a lot of different trials done, and there's also a long-term extension trial. The drug is given 600 milligrams weekly for 4 weeks during the induction phase, and then there's a maintenance phase, 900 milligrams every 14 days. Important point here is that everybody is getting the same dose. That's probably not a good thing. You don't have to be a scientist to know that patients don't process drugs in the same way, and that drugs are likely cleared differently between patients. So one size fits all doesn't work for medications in general. And we'll come back to why this could be a potential issue. So when you look at the data, the TRIUMPH trial was the pivotal phase 3 randomized trial. And here patients were randomized to either placebo or to eculizumab. And then they were allowed to cross over at week 26. So this is what we call LDH levels. This is a marker of hemolysis. And you can see that at the beginning, everybody had very high LDH levels. The patients who were initially treated with eculizumab have a sharp and sustained reduction of LDH. But the patients who were on placebo didn't have their LDH lowered until the crossover point. And LDH is hemolysis. That's the destruction of the red blood cells. So we're already seeing that eculizumab substantially reduced the risk of hemolysis. It also reduced the risk of thrombotic events. There was a 92% reduction of thrombotic events in patients who were treated with eculizumab. It also reduced thrombosis even in patients who are on anticoagulants. So that's what this slide is showing. So even if you were on warfarin, Coumadin, there was a reduction in thrombotic events. I'd already mentioned to you that 64% of patients have some degree of chronic kidney disease. Treatment with eculizumab also improved chronic kidney disease over time. And that's what this slide is showing. So overall, around 34% of patients had some improvement in their chronic kidney disease. And this is more commonly seen in early stage kidney disease, which kind of makes sense. So you want to try to intervene before they get really bad, before patients develop really bad kidney disease. It also reduced the need for transfusions. So overall, there was a substantial reduction in transfusions in patients who received eculizumab, and otherwise known as Soliris. It also improved symptoms. So patients who were treated with eculizumab had a reduction in their symptoms, both fatigue, shortness of breath, and pain. It also improved what we call pulmonary hypertension. Now, pulmonary hypertension is basically blood pressure within the lungs, and that can be high in patients with PNH, and it can lead to patients developing shortness of breath, problems with their exercise tolerance. That was also improved in patients with PNH. All right, now I want to shift gears a little bit and move away from eculizumab to another drug that's known as ravulizumab. And the other name for that is Ultomiris. It's very similar to eculizumab, but the antibody has been changed in two main ways. And I have graphs and pictures here to show you what we're talking about. One change is that the ravulizumab actually releases the complement once the complement is ready to be destroyed. So what happens when these antibodies bind to complement? There's these cells that come along and basically cleans up the complement and destroys the complement. That's considered to be a good thing in this situation because one of the issues in PNH is that you have complement activation, too much complement that's being made. So you want to try to get rid of it. And so that's what's happening here. But what's unique about Ultomiris, ravulizumab, is that unlike eculizumab, it releases the complement once the complement is ready to be destroyed. Eculizumab would stay bound. So that's one change. The other change between eculizumab and ravulizumab is that ravulizumab can be recirculated and released. So it has these modifications in the heavy IgG changes, heavy IgG regions that allows it to be recirculated through this FcRn binding. So that's what this slide is showing, is that basically, unlike eculizumab, ravulizumab brings the complement to be destroyed, releases the complement, and then gets recirculated. So what does that mean? Ravulizumab stays in the body longer. And from a patient's perspective, the advantage of that is that you need less frequent dosing. So there have been 2 main trials done evaluating ravulizumab versus eculizumab in patients with PNH, what we call the naive trial, also known as 301, and what we call the switch trial, or 302. Both of these trials randomized patients to either receive Ultomiris, ravulizumab, or eculizumab, which is Soliris. So they have that in similar. Both of these trials are what we call non-inferiority trials. Now, in medicine, we do have different ways of evaluating drugs. The most common way, which most of you are likely familiar with, is what we call a superiority study. And that's when we say one drug is better than another. But another way that we have to evaluate drugs is what we call non-inferiority. And with that, we're saying we don't have to show that this drug is better. We just have to show that this drug isn't worse. So that's what a non-inferiority study is. In what circumstances might we do a non-inferiority study? If a drug is less expensive, if a drug is much safer, if a drug has to be given less frequently and is easier to give to a patient. So that's where the ravulizumab comes in. Because ravulizumab sticks around in the body so long, it doesn't have to be given as frequently as eculizumab. So the people who developed this drug knew that they didn't have to show ravulizumab was better. They just had to show that it wasn't worse. So that's what a non-inferiority study is. And that's what both of these trials had. So what was the difference between 301 and 302? The patient population. 301 was upfront treatment. These patients had not yet been treated for their PNH. 302 was second line treatment. These patients were already on eculizumab and then switched to ravulizumab. Both of these studies were adult patients only. No pediatric data to date. And technically, ravulizumab doesn't have an approval for pediatric patients, whereas eculizumab does. There is data in pediatric patients for eculizumab. So this is the clinical trial design. You have this screening period. This is the 301. This is the upfront treatment. Patients were randomized to either get ravulizumab or eculizumab. And then for the naive study, patients had to be on stable doses of eculizumab. Now, that's one of the big concerns about ravulizumab. Patients had to be on the standard dosing of eculizumab, 900 milligrams every 2 weeks. That's the patient population that was studied in the switch trial. There are studies being done, but right now, there's no published data to support switching patients from eculizumab who are on higher doses of eculizumab or who are on more frequent dosing of eculizumab. There will be, but for right now, this switch trial was only done on patients who had been on 900 milligrams of eculizumab every 14 days. And as I said, this was a non-inferiority study. Both of these had a primary endpoint at week 26. And when you look at the published data, we have the 301 study up here at the top. There was a co-primary endpoint of transfusion avoidance and normalization of LDH. And both of these were to the right of 0. And you can see that that favors Ultomiris. And both of these met what we call the non-inferiority endpoint. That's where these yellow dots are. If this study had failed, this green dot would have had to have been on the other side of this yellow dot. And you can see that it almost met what we call superiority. Superiority would be when these confidence intervals don't cross 0, but it didn't. But it certainly met the primary endpoint, co-primary endpoint of non-inferiority for transfusion avoidance and for normalization of LDH. So the FDA has approved ravulizumab for the treatment of adult patients with PNH. Now, this And the graph below is what we call the switch trial. Now, the switch trial had a singular primary endpoint, which was LDH change. And you can see that favored Ultomiris. It was almost superiority, but didn't quite reach it there because you can see that the confidence interval crosses 0. But certainly Ultomiris was non-inferior to eculizumab for both switching and for upfront treatment. I wanted to give you some positive information here, and I've already mentioned this, but this is survival data in the current era of patients who are treated with complement inhibitors, showing that survival of patients with PNH is similar to age and gender matched controls. And this is long-term safety data with eculizumab. Boy, I feel like someone else is advancing my slides. If they are, please don't, but it's probably me. All right, so I wanted to mention a bit about what's called C3b. C3b is still active even in patients who are treated with eculizumab. Remember, because eculizumab blocks the terminal complement, but not the proximal complement. So C3 is still activated. That's the proximal complement. C3b can actually bind the red blood cells, send the red blood cells to the spleen, and the spleen can kill these red blood cells. So even in patients who are treated with complement 5 inhibitors, they can still have what we call extravascular hemolysis. So that's a clinical problem in patients who are on ravulizumab and eculizumab. Not all patients have a big issue with extravascular hemolysis, but some do. Why do some patients have a big issue with extravascular hemolysis who are on ravulizumab and eculizumab and others don't? Poorly understood. It's likely multifactorial. And honestly, we can't predict it. But it does appear to be anywhere from 10 to 30% of patients who are treated on complement inhibitors still have a big problem with extravascular hemolysis and still need intermittent transfusion support, which brings us to the third drug that is now FDA approved to treat ravulizumab, and it just to treat PNH, sorry, and it just happened. So we're all very excited about it, but it's called pegcetacoplan or Empaveli. And this drug previously was known as APL2. And what it does is it binds to C3. So it's acting at an earlier time point in the complement cascade. C5 is the terminal complement. This is where ravulizumab and eculizumab act at this point. But APL2, pegcetacoplan, acts at an earlier time point, C3. And binding to C3 inactivates the proximal terminal cascade. And now you're seeing why the Apellis product can be effective in patients who have extravascular hemolysis, because it blocks the formation of C3b. This is what the chemical structure looks like. One issue with Empaveli is that it's complicated administration. So it's given as a 20 milliliter subcutaneous infusion twice weekly. And sometimes you may have to increase to 3 times a week if the LDH is elevated. It's self-infusion at home. You can do it at home or you can do it at clinic. The infusion time is 30 minutes with 2 sites or 60 minutes with 1 site. There may be patients on the call who are being treated with this medication. There are online YouTube videos of a patient who's self-administering at home, and they have nice instruction and nice support mechanisms that are in place for this agent. This agent is given through what's called a REMS program, REMS, which means that the physicians who prescribe this medication have to be trained. Why? Because of the potential infectious risks. So there was a concern that if you completely block complement, you're going to really increase the infection risk. So it is important that patients who are treated with this agent not only be vaccinated for meningitis. Now, I have to tell you, this meningitis is also a concern for ravulizumab and eculizumab. So you should really protect a patient against meningitis, whether they're getting ravulizumab, eculizumab, or pegcetacoplan. But since pegcetacoplan also inhibits the proximal complement cascade, there's also a concern about Haemophilus influenza B and Streptococcus. So in an ideal situation, you would want to immunize patients for all 3 of these bacteria before treating with pegcetacoplan. If they're really sick and you can't wait, you can give them prophylactic antibiotics vaccinate and treat all at the same time. And then after 2 weeks, you can stop the prophylactic antibiotics. Now, for ravulizumab and eculizumab, we're really talking about just vaccinating for meningitis. This study was compared to eculizumab. I'm sorry, this drug was compared to eculizumab. It has an interesting design, and I'll try to spend just a few minutes talking about that because I think it's important to have an understanding of what that is. But patients were treated with pegcetacoplan plus eculizumab up front. And for patients to be eligible to go into this study, they had to be on a stable dose of eculizumab for 3 months. So they could be on any dose of eculizumab, but it had to be stable for at least 3 months. And they had to have gotten at least 1 transfusion within 12 months, and the hemoglobin had to be less than 10.5. So basically what that is saying is that these patients were not responding as well as they should have to eculizumab. So was that because of IVH or EVH, intravascular or extravascular? That I can't really tell you. And it's probably a mixture, which is one of the criticisms of this study. Another criticism is that there is no data, at least randomized, for pegcetacoplan given as an upfront treatment. All of these patients were already on eculizumab for at least 3 months. Now, this neutrophil count of greater than 500, platelet count of greater than 30, absolute retic count greater than 1.5, this is kind of standard. Basically, they don't want the aplastic anemia patients or MDS patients necessarily to be in this study. So they were kind of like, we don't really want the horrible bone marrow failure patients in this study. So I can tell you that that's a common thing with many of the classical PNH trials. So once they had the 4-week run-in, that's when they were randomized to either receive the pegcetacoplan or the eculizumab. And then at a later time point, they were treated with pegcetacoplan alone. The primary endpoint of the study was the average change from baseline hemoglobin from week 4 to week 16. This is the randomization strategy. You're going to see that it's pretty well balanced between both arms. This is one of the primary endpoints of the study, which is the mean hemoglobin change. And what this is showing is that after patients were randomized and they were on the double therapy, you see, here they are at the stable endpoint at 3 months. Hemoglobins are pretty low, 8.7 with eculizumab. I can tell you that in the real world, we would be increasing the eculizumab dose, adjusting the eculizumab, trying to do something to get better hemoglobin control. But in this study, patients were enrolled into the trial and they were added the pegcetacoplan and their hemoglobin went up. Now, did their hemoglobin go up because the IVH was better controlled or EVH was better controlled? That I can't tell you. And then they were randomized to be on pegcetacoplan alone or eculizumab alone. And the patients who crossed over to eculizumab alone, their hemoglobin went down. And the patients who stayed on pegcetacoplan, their hemoglobin stayed up. So this study met the primary endpoint and of course was FDA approved. And you see in the top bar here that pegcetacoplan was superior to eculizumab when it comes to hemoglobin change over time. Major side effects, very similar between pegcetacoplan and eculizumab, except for injection site reactions. That's because of the administration of pegcetacoplan, which is this subcutaneous infusion. So it's not surprising that there's going to be some injection site reactions. Transplantation is the only cure, but there is a high treatment-related mortality. This is showing a standard survival curve for transplantation. Best indication for transplantation is patients who have recurrent hemolytic crisis. If you're transplanting for blood clots, typically bad outcomes. This is our own internal data for transplantation. The 5-year overall survival was 70%. So, you know, there is this early upfront treatment. What we historically, or what we now recommend for patients with PNH is that transplantation be considered if their hemolysis is not well controlled with current therapies, or if they have recurrent blood clots on current therapies. Those two would be the primary indications for transplant. Really, upfront transplantation for classical PNH alone is not being done. with some exceptional circumstances. I always like to talk a little bit about the future, and there's a lot of excitement about the future because we have some drugs in development that can actually be given by mouth. So that, from a patient perspective, would be very friendly for the patients. But there's this drug. This is actually owned by Novartis, LNP023, iptacopan. It's an oral factor B inhibitor. There was a phase 2 trial where iptacopan was added on to eculizumab. This was a positive trial. And now there's a single arm open phase label trial with oral 200 milligrams twice a day for naive patients, so as upfront treatment. So this drug has not yet been approved by the FDA, but everyone's very excited about this. It's a factor B inhibitor, so it inhibits both pathways of proximal and terminal, so it could inhibit both EVH and IVH. Another drug used to be owned by Killian, now owned by Alexion, ALXN 2050, danicopan, is an oral factor D inhibitor, also inhibits both IVH and EVH, given as an oral drug 3 times a day. Phase 2 trials add-on was positive, and there's a phase 2 single-arm study that's currently enrolling for both naive and patients with an inadequate response to eculizumab. There's another drug that used to be owned by Roche, called crovalimab. It gives an IV loading dose and then sub-Q anti-C5. So the mechanism of action is very similar to ravulizumab and eculizumab, except that it can be given as an injection at home, 680 milligrams once a month. Once every 4 weeks was effective at controlling C5 activation in this trial called the Composer trial. So these are 3 new agents that are very exciting. And I have my summary slide here, so hope we'll have some time for some questions. But PNH is a chronic, life-threatening, complement-mediated disease. Blood clots is the major cause of death historically. It is acquired, so it's not something that you're born with. And for patients who are on the line who have PNH, you didn't do anything to get this. It's not something that you caused. It does have an association with other bone marrow failure disorders like MDS and aplastic. There are now 3 FDA-approved treatments, but only 1 for kids, and that's eculizumab. So the labeled indication for eculizumab is treatment of PNH to reduce hemolysis. It was approved on March 19, 2007. Ravulizumab is FDA approved for the treatment of adult patients with PNH. Approval date, December 21st, 2018. Pegcetacoplan, treatment of adult patients with PNH, approval date, May 14th, 2021. About pegcetacoplan, there's a lot of difficulties that we've all had to endure with COVID. And honestly, I wouldn't have expected this, but drug launching is another one. I'll tell you, I haven't treated any patients with pegcetacoplan myself. If there are patients on the call that are on pegcetacoplan, maybe we can hear from them and what their experience has been. But I haven't treated any patients, nor am I on the REMS program. And we haven't had any really big meetings about pegcetacoplan as we would typically have. And I think part of that is because of the COVID, situation and the fact that we haven't been able to gather as a group, because there are, like with any of these very rare diseases, a group of physicians that are strictly dedicated to the investigation of these diseases. So the familiarity with this agent in my own experience is less, honestly. There's no superiority studies that have been performed for upfront treatment comparing eculizumab, ravulizumab, pegcetacoplan. So a natural question that you might have is which one of these are the best for upfront treatment? And honestly, I wouldn't be able to answer that question. There are oral agents that are in active development. Of course, we're all very excited about that. There is, to its advantage, honestly, long-term safety data and long-term survival data available for eculizumab. And that's because of the fact that eculizumab has been around longer. Transplant is curative, but there's a high upfront mortality. It is important to follow LDH over time, and EVH is an important component of PNH, extravascular hemolysis, of course, in some patients. So with that, I will end the talk, and I want to thank everyone for your attention, and I do appreciate the opportunity to speak to you today, and hopefully you gain something from it. And now I'll open up to any questions people may have. Thank you very much.
Thank you, Dr. Scott. A few questions, and you touched on the impact of COVID, of course, but if you could elaborate a bit more, are there any particular concerns as the pandemic is continuing for PNH patients to be aware of, and that they should be just guidelines to follow in general for them?
Yeah, I'm glad that question was asked. And the truth is, there's no factual data that I can give them because there's no specific information for PNH patients in regards to response to vaccines, risk of acquiring COVID, risk of developing serious COVID. So when facts are few, opinions are many. And unfortunately, I found that many of my colleagues are more fervent about their beliefs when there's less data to support their beliefs. So, I mean, I can tell you, what I think. And certainly, I think that PNH patients should be vaccinated. I strongly support that. And is it possible that PNH patients are less likely to respond to the vaccines? Yes. Do I factually know that? No. Is it possible that patients who acquire COVID may have a more severe form because they have PNH or because they're on treatment with complement blockade? It's possible. But it's also possible that they may not. So that we don't know. And I'm sorry that I can't be more definitive, but what I would say is that if you are a patient with PNH, or if you are a patient who's on treatment with complement inhibitor therapy or pegcetacoplan, you should be vaccinated. I will give some advice, and my advice would be to get that COVID vaccine, to try to work it around your dosing of whatever treatment you may be on. Because what you want to do is you want to be dosed with the vaccine as close to your most recent dose of complement inhibition, because that vaccine administration is really going to drive up your complement. And so I think it's important to try to give the vaccine like day 2, day 3, day 4, even after eculizumab or after ravulizumab or after pegcetacoplan. Of course, pegcetacoplan is given twice a week, so that's going to be a little bit easier to do. But with ravulizumab, that's going to be a more important timing issue. I hope that was helpful.
Yes, thank you. We have another question. Can we take a specific vitamin or food to help our blood?
Well, I'll just say that it's always good to have a healthy diet. It's always good to remain physically active, but there's no specific vitamin or food that I would say PNH patients should do in particular.
Okay, thank you. You mentioned, of course, several clinical trials that were critical in the development of the new treatments. And can you explain in general for PNH patients who may be considering a clinical trial or who are aware of one, just the role of the patient in that, how if they should be asking their physician about that, and how important it is for them to participate? As we saw, it led to several recent developments. So that was extremely important for them.
It is very important. And all of our guidelines say that participation in clinical trials should be encouraged. So I would strongly encourage patients to participate in clinical trials. Without patients participating in clinical trials, we will not have the development of oral agents. So I'll give a website out. It's called clinicaltrials.gov. And I'll say that again, clinicaltrials.gov. It's easy to find. And honestly, I think it's fairly easy to work your way around, even for those people that aren't very internet savvy. You can go to that website and just type in PNH and then type in active clinical trials, and it's going to bring up all of the clinical trials. And not only that, if you click on the clinical trial, it will tell you where those clinical trials are open. Clinical trials in PNH are very difficult to perform, and that's because the disease is so rare. And so we're really relying upon large catchment areas to do these types of clinical trials. So I strongly encourage patients to participate, and hopefully we'll get an oral agent approved soon, which I think will be good for everyone.
And as a follow-up to that, AMDSIF recently launched a PNH patient registry and this is for patients to enter their data. I understand that clinicians, there has been an ongoing
Yes,
clinician entered
yes.
data registry, but could you also elaborate on the importance of patients participating in a registry and the difference between a registry versus a clinical trial?
Okay, thank you. So there are two registries. There's the AAMDS registry, and there's also the clinicians registry, which you mentioned. And that clinicians registry would be found on the clinicaltrials.gov. They are a little bit different, and that's good. The AAMDS, of course, is more patient-centric, which I think is very important, asking about symptom control and following people over a long, long time. So they're both relevant. But to answer your question, the difference between a registry is asking about long-term outcomes and following, responses to agents, how patients do. It allows us to follow people over a longer period of time. Clinical trials are generally intervention focused. So they're giving a specific drug to treat a person and then doing a shorter term follow-up to see how patients do over shorter term. So they tend to be shorter term, clinical trials tend to be shorter term, and they tend to be intervention focused. What are we going to give to make this disease better? Whereas registry studies tend to be longer term and are more focused on long-term clinical outcomes.
Thank you. That's very helpful to explain the difference. And for patients or caregivers who are viewing, at the very top of your screen, there's a link to the Global PNH Patient Registry for more information. So after the presentation is concluded, we certainly encourage you to visit that for more details. We have another question. I know a lot has happened over a year and people are turning to natural solutions. What's your take on a PNH patient using essential oils to help their immune system?
Well, I don't have an issue with that. I don't think it's likely to cause them harm, but I would not promote that as solitary therapy for patients with PNH because those would not necessarily prevent thrombotic complications, which is the major cause of death in patients with PNH. So as an adjunct to additional treatments, I think that's great, but as primary therapy, I would not support that.
Thank you. Please give your thoughts on a third dose of COVID vaccine for PNH patients.
You should do it because I think that we don't know for sure, but there may be a suboptimal response in patients with PNH because there is the potential of some immune suppression, even if you're not on complement inhibitors, but probably for sure if you're on complement, probably for sure, what a statement that is. That just tells you how little we know. But yes, I would say that PNH patients should receive their third dose and they should be treated as other immunosuppressed or cancer patients are treated, particularly if they're on complement inhibition, or particularly if they have coexisting marrow failure disorder like HD or MDS. And remember, that's supposed to be 3 months after their second dose. So you get the first dose, then you get the second dose, and then 3 months later, you should get the booster. And I would recommend PNH patients to get the booster. Thank you for that question.
Yes, thank you. We have another question. My doctor said PNH medicine is similar to not having a spleen. In other words, getting sick could be very bad. I was told that some people always carry antibiotics. I used to travel around the world to developing countries. Is this risky? Assuming, of course, that can continue in the future.
Well, that's a complicated question, a good one, but a controversial topic within PNH. So what you said is true, and there's different approaches, and there's different arguments. So I'll tell you what the arguments are. But what I would say is that given your unique situation of traveling around to different countries, perhaps you would consider having prophylactic antibiotics on hand for your particular circumstance. But in the UK, for example, they do give prophylactic penicillin even to those patients who have been vaccinated if they are on complement inhibition. That's not the general approach that's been taken in the United States. In the United States, if patients are vaccinated, we tend not to give, at least yeah, I'd say it's fair to say in the US, we tend not to give prophylactic penicillin, and that's because of the emergence of antibiotic resistance and the concern that the prophylactic use of penicillin will lead to the emergence of Neisseria that's resistant to penicillin. And then if patients actually need to be treated, they're not going to be able to respond. And that would be a very frightening situation because Neisseria meningitis is an infection that needs to be treated emergently and quickly, and you need a quick kill rate. And beta-lactam antibiotics are what we call bactericidal, whereas vancomycin, which is our backup plan, is bacteriostatic. So it slows the growth of bacteria to allow your immune system to catch up. So it has a little bit different way that it works. So that's a concern. We don't want Neisseria to become resistant. But those are the two different approaches, the two different arguments. And so given your unique situation, I think taking or actually having prophylactic penicillin if you're on a complement inhibitor would be probably a good thing to do in your unique situation of traveling a lot to third world countries.
Thank you. That's all of the questions that we have today. And in closing, Dr. Scott, I know you mentioned several things on the horizon. We've had new drugs approved recently. Any closing thoughts from you before we wrap up the session?
I really appreciate this society in promoting PNH as a disease. It's very rare. And honestly, without these kinds of sessions, I don't think that we would drive clinical trials forward. And I want to thank all the patients on the line for their interest and for participating in the conference today.
Thank you. And thank you, Dr. Scott, for sharing your time and expertise with us today. One special note for PNH patients, we are having a special PNH walk, part of our March for Marrow series on October 17th. And there's more information on this conference platform in the exhibit section on AAMD-SIF March for Marrow, if you'd like to participate in that event. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMD-SIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Be sure to visit our exhibit hall. Our next session, the award ceremony, will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMD-SIF Medical Advisory Board and team are here to help you and your family, as we have for the past 37 years. This concludes the session.